Started. Hello, everyone. This is Frederick with the Stretch to Win Institute. I'm here with Susan Bonin, and I'm going to let her tell her amazing story of how she came to us, our class, got some training, and how she's using it, I think, in a very unique way. So welcome, Susan.
Hi, thanks for having me.
All right. Well, I'm real excited to get going on your story. It's amazing, and you have probably a lot to say, so I'm going to let you say it. Why don't you start off with maybe how you found out about us and why you decided to train with us, and then how you're using it.
Okay, so I'm a physician assistant in the emergency department, and I think I've told you multiple times while we've spent time together that it's a pretty stressful situation. So I was looking for a way to sort of be in the health maintenance side of things instead of having people come to the emergency department all the time. And that started a few years ago, 7 years now, actually, at a place called Evolution Barbell, which is a gym. It's owned by a friend of mine, and he needed an extra trainer. So I went and got my certification to be a personal trainer. And we worked hard, and the business built up really quickly, and our clients got really strong really fast. And what we noticed over time is that while they were strong, they had terrible mobility. And so we embarked on the path of creating mobility to try to avoid all of the injuries that come because of that condition. So I started doing yoga. I went for a 200-hour yoga training, and we implemented that, and that was great. But then we got wind of something called bulletproof stretch, which was designed off of Frederick stretch therapy. And it was just a quick 15-minute warm up, cool down kind of a stretch to get your clients ready to perform their physical activity for the day or to finish off their activity, because most people don't take the time to stretch after they're finished. And I went to this class and I'm like, this is kind of intriguing. This class is not enough. Where did it come from? And that's when I found out about Frederick stretch. And the first time that I came out to Arizona to learn about this technique, I was just blown out of the water at how quickly people felt relief. You know, even amongst all of the students working on one another, everybody has, you know, low back pain or an ache in their calf or whatever. We're all athletes. And how quickly they felt better. And by the end of the week, how our bodies had changed after we practiced on one another and worked on one another, and how much more mobile and more fluid we were moving just from having experienced this technique. When I went back to the emergency department, I had several colleagues who asked me where I had been for the week. And, you know, basically we're calling it voodoo, and you know, what is this exactly? And they kind of like gave me a gentle ribbing about it, but I don't think that they were believers. And then one day, one of my physicians got a headache, and he took Tylenol and it wasn't going away. And he tried fluids and it wasn't going away. And that was pretty much the extent of what he could do in the emergency department because he was still working. And I said, hey, why don't you give me 5 minutes, lay down on the table, and I'm going to work on your head and neck for just 5 minutes. And you let me know if your headache is better. 5 minutes later, we got done. His headache was completely resolved. He was sheepishly admitting that he had no more pain, and then began the conversations about, how did you learn about this? Where's the science? You know, what's it based on? What are we talking about? And so we started talking about fascia and the way that, you know, having tightness in the fascia can really affect the way you feel day to day, more than just mobility issues, but those headaches and aches and pains that you're dealing with every day that you don't have to deal with and you don't have to medicate. So then we came to level 2. And in level 2, we learned a bit more about how to really get into the joint and how to safely affect the tissue that surrounds the joint. And that really got me fired up, because I immediately thought about reducing joints in the emergency department. It's something we do at least 4 or 5 times a week. And it was this huge cumbersome procedure where you had to give conscious sedation, you needed 2 nurses, you needed to have a physician in the room. you're basically taking a third of your ED staff to go manage this one thing. Once you gave the conscious sedation, it took about 30 seconds to a minute to reduce the joint. And then you had the hours-long sequela of, letting the patient wake up, making sure their airway is safe, all of these things. And I thought, how can I employ FST to make this different? So in comes a gentleman who had an opioid addiction. And he had dislocated his shoulder, had fallen down on an outstretched arm, and had a posterior shoulder dislocation. And all he kept saying was, oh my God, I can't have pain medicines. I'm only in recovery 6 months. It'll put me in a tailspin. Please don't give me opioids. And we're thinking, how are we going to reduce this man without creating a tailspin for him? So I talked to him a little bit about this technique and basically told him, I don't know if this is going to work, but if you're willing to engage with me, we can give it a try and see if it will go. So he was all for it. And we started with just deep breathing. His heart rate was high. He was sweating. Clearly that was pain. So we started with a deep breathing technique that we use in yoga. And I asked him to imagine drawing a white light from the front of his lips deep into his lungs and watching his lungs fill up with light, and then exhaling so that the light would swirl in front of his lips, and then drawing it back in again. And as he prolonged his breath, we watched his heart rate downregulate from 115, 116 down into the normal range of 80, and he started to relax. During that time, I started to massage his anterior pectoralis muscle, subscapularis, trapezius, just trying to get things to loosen up. And my physician was kind enough to come in and support his arm, because the great majority of pain in the dislocation is the hanging arm that's stretching all the tendons and ligaments and soft tissues. So he was supporting the arm at a 90-degree angle. And as I felt things loosen up, I asked him to create just a little bit of traction at the elbow, downward traction. And I had immediately rotated the scapula once it was free. When that happened, the joint gently slid back into place and the procedure was over. It took us about 15 minutes total. And the patient was awake, alert, oriented. We put him in a sling to protect the joint, and he was out the door. And he was thrilled. He wrote a letter to our CEO and said, they really cared about what I was telling them. They didn't treat me like an addict, but they listened to what I had to say and they helped me through this, and it wasn't painful at all. And so, bolstered by the win, we embarked on trying this multiple different times and in multiple different dislocations.
So we'll get to that, because I'm going to talk about the comparison. 15 minutes, no medications used, in 15 minutes complete. Compare that to the way it's usually done, how long, what's required, how long it takes, what trauma occurs iatrogenically from doing the procedure. Cover all that, and let's make a comparison, apples to apples.
Okay.
What did you change? How's the procedure so different than what is normally done? And what is that called, if it's called anything? The normal procedure.
So I don't know that there is there are several different techniques that you can employ when you reduce a shoulder. There's a leg reduction that holds the hand, and abduction, and then internally rotates. And that's usually used for an anterior reduction. There's a coker that gives you external rotation of the arm, and then you lift the arm as far as it can go and externally rotate it further. The Davos is where the patient actually self-reduces. They lie down and put their fingers around their knee and lean back, extend the neck, and hold the leg in place. And that's a self-reduction if you're out in the field. That's mostly used by Army personnel. External rotation, holding the arm at 90 degrees and then just giving it a slow external rotation. And then the Cunningham procedure has you sitting forward with the arm hanging, and the practitioner just gives gentle traction forward, and the patient's trying to sit up as straight as they can to give counter traction. I think when we're doing this procedure, like I've described, we are kind of taking a bit from each of these sort of techniques. I too have the patient sit up really straight, but I get behind them. And part of the down regulation is having my body close to their body, which gives them a sense of comfort. And then the second practitioner is holding their hand or their arm very closely so that they feel really supported and can relax into it. Now, typically, you have a patient up at about 80 degrees. You have 2 IVs in place, which of course IVs can be easy or can be extremely difficult depending on how many times you had access, if the patient's dehydrated, whatever. And we usually use one of 2 medications, propofol or ketamine. Now, propofol works on GABA. It inhibits GABA. So it's sedative and it's a relaxant all in one. The problem with using propofol is that it has cardiovascular effects. You can get a dysrhythmia from it. You can become hypo or hypertension. You can stop breathing altogether. You can have an allergic reaction to the medication. If once you wake up, you can be dizzy, have headaches, changes in vision, hallucinations, and just basically feel unwell until the drug leaves your body. And it's got a short active half-life, but you feel the effects of it for probably 12 to 24 hours. So you can't drive for the rest of the day. You're pretty much done with your day. You have to go home and rest, which you should anyway post-production. But, you know, we'd like for you to go out and have a nice lunch and celebrate your shoulder reduction instead of having to be poured into bed. Ketamine is a different one. And you see people love ketamine these days. They use it in depression and anxiety, but as a conscious sedation mechanism, it's a non-competitive antagonist of NDMA or NMDA, my apologies. And so it blocks your nervous system input to the area and allows everything to relax. Again, side effects, dizziness, blurred vision, vomiting, hallucinations. Sometimes if you're having a bad ride with the ketamine, you can wake up with extreme fear. You can have transient laryngospasm where you feel like you can't breathe, and that's incredibly uncomfortable. You can have respiratory depression. It is cardiovascularly stable, so you're less likely to have side effects on the heart. But, you know, I've had people come out of ketamine and be just fine. I've had people come out of ketamine that required what's the nice word to say this? We basically had to hold them down and restrain them because they were just so wild from those hallucination that they were having that it really was uncomfortable for them and for their family. And families typically want to be in the room during these procedures. So, you know, using those 2 drugs, you always have this little bit of discomfort. The family sees the crash cart roll to the outside of the room in case we need it. You've got oxygen on their nose. You've got a CO2 monitor to make sure that they're not getting apneic. You have to put in 2 lines in case you have to go into resuscitation. And it's just while the patient doesn't feel anything and isn't aware of the procedure, there are so many other things in the background that can happen that are really needless at this point.
Needless based on your new procedure?
I mean, you know, we have sort of ticked the mark on the opportunities that we've had to perform this procedure over the last 6 months. And we've done upwards of 25 reductions at this point using this technique. We failed 2. The 2 that we failed both had prior orthopedic surgery to prevent shoulder dislocation. So these were repeat offenders and they had been tied down. So it wasn't so much overriding the musculature and the nervous system, but you actually had a surgical tie down that was scarred in. And so in that first attempt to get at it, it's going to be very difficult to override that. But we tried. The patients were willing to give it a try. We just, cut it short because it just wasn't working and we weren't getting any movement at the joint. So the side effect of a reduction, a high velocity reduction, where you see on TV that people are really yanking hard and they're using counter traction and they're just letting the joint fly back into place, is something called a Hill-Sachs deformity, where you get a shearing off of the humeral head from grinding across the processes of the shoulder. So, you hate to be the one to cause the side effect of the procedure. Sometimes Hill-Sachs occur during the dislocation itself. If it's a high velocity traumatic dislocation, you may get that deformity initially, but we don't want to cause it on the back end by forcing the humerus back into the glenoid fossa. So, we tried to take it really gently. And the techniques that were extrapolated from FST were basically loosening the fascia, getting into the muscles, getting them to relax, the down regulation, and the gentle traction. You typically see people grab onto an extremity to try to reduce it, and, employing that open hand technique and just bringing the weight of our body down to give that gentle traction. The joint doesn't need that much. A little bit of coaxing, a little bit of internal or external rotation, and it's going to go right back into place.
I just love the fact that it sounds to me you're doing what we teach, basically, but in the ER setting, which is novel or new for us to hear about this, is wow. I mean, you would almost think, why wouldn't they have tried that originally when they first came up with these techniques? There's a violent way to do it, and then there's a gentle way to do it. Why does it always have to be violent or, so much invasiveness, right? And the fact that you did it with so little noxious aspects to the technique, the person could relax. It's scary to be in an ER with something out of alignment, dislocated, right? Much less amputated or something. The fact that you were able to calm people down, and the body knows when something feels right or is going to feel right. It knows when you set it in that mode, it cooperates, right? They don't fight it. They know it's the right thing. They know instinctively, intuitively, they're in good hands. And that's why it sounds like the nervous system allows you to let them go back into correct alignment without fighting it, protecting. Because if it was bad or noxious, so the body was trying to protect itself, they wouldn't let you do that.
Sure. I think a lot of it goes to the fact that in the emergency department, we have just a few minutes to create rapport with these people. So you really have to approach it very gently, and you have to do all the things that they teach us to do. Sit down, engage your patient, give them the choice. I've had some people say, absolutely not. I don't want to know anything. I want to be knocked out. I don't care about the risk. And that's fine. That's a choice. Most people don't want to go through that. And, I think they're a little curious about, how this procedure actually goes. I think a lot of people have that curiosity is how you're going to do this. Also, you have the fact that while the patient in a typical procedure with conscious sedation is in the department a long time, the provider's time in the room is short. So we're there, we push the meds take effect within 30 seconds to a minute. We get our reduction done in another minute, we're out. But it ties up our nursing staff. And this was really born during COVID, when we didn't have a lot of nursing staff. I mean, you still hear about nursing shortages. So to take up their time to essentially babysit someone coming out of sedation is hard on them as well. And so if we don't have to put them through all of the procedures and paperwork and all of the things that they have to do, we don't have to put the patient through it, then it's worth a shot. A lot of these other techniques that I told you about are non-sedated techniques. Ours is just a little bit different. I think it's a little bit more personal. Like I said, my body is very close to your body during this. So if you have anyone who is uncomfortable with being close to another person, this is not going to work, right? We have to downregulate them. When they're breathing, I'm breathing with them as I'm getting into their fascia. They're sort of matching my breath, even if they're a bit anxious. They can't help it. If you're in a room and someone's yawning, you're yawning with them. If you're in a room and someone's panting, your heart rate sort of increases and you're uncomfortable and maybe your breath increases a little bit. So part of the down regulation has to be the practitioner's demeanor as they enter the room. And that goes a lot to establish the rapport and deciding whether or not this patient is going to be a good candidate to do a non-sedated technique.
Well, my dear, I mean, you may be an ER physician's assistant, but you're a healer. And that's what you bring into the ER, which is really an incredible story. I would love to see you start teaching this to others. What is your goal with this knowledge that you've acquired? You've done the sort of the work, you've tried it on at least how many people now? You said
25.
25 people. And besides those who've had surgical intervention, I won't count those for now because their anatomy has changed, right?
Mm-hmm.
But the other people, 100% reductions, right? No trauma,
Right.
quick, no medication, no side effects, in and out, relatively speaking, compared to others have to stay for a while if they're medicated, you know, and on and on. So yeah, what's the next steps to bringing this to, you know, more ER departments? What would you
So,
like to
you know,
see?
I would really love for the opportunity to sort of be able to speak to people and to have them try this technique, even if, you know, there's lots of things that you don't believe in, right? There's lots of things that you hear about and immediately you're not quite so interested. But if you give things a try, I think that it would be very cool to see the paradigm shift to always using high-powered medications and bringing it back to engaging your patient and, you know, using a little kindness. It locally, it is for shoulder reductions, right? We could probably move it to hips and elbows and I mean, we reduce children, nursemaids' elbows, which is a really quick external rotation. It happens in a hot second. We never think about sedating the small children. You know, they're not accustomed to pain. And so we can go right in there and be like, oh, does this hurt? Click, and it's in. And before they even know what's happening, the reduction is done and they're taking the lollipop from the nurse's hand.
Mhm.
So do things always have to be so complicated is my
Mhm.
question. And
Mhm.
coming into FST and seeing the way we affect one another with our energies and with our kindness, you know, can this move into a global perspective in medicine where we stop worrying about seeing, you know, one patient every 15 minutes to taking just a few extra seconds to engage and making that person feel comfortable, letting them know that you do care about what you're doing, and giving them a comfortable space to be treated. Right now, we're dealing with a lot of distrust from the public, whether it be from media saying that, you know, we double bill on purpose or we do this on purpose and it's just a big scam. It's just a big, you know,
Yeah,
business that wants to take your money,
yeah.
to having people come in and feel like we really cared about their issue and really wanted to make them feel better.
Mhm. Yeah, we need that
As
change.
as a self-proclaimed healer, I enjoy those moments when I get to engage in that way.
Well, my dear, I can see, you know, the future is bright for you, and I do see this reaching the right people. You know, when it resonates, it's going to reach the right people, and positive change will happen. So we're with you there with supporting your work, and we can't wait to see you back here again for more training. But in the meantime, I want to thank you for your time. You can stay on. We'll talk some more after this is over.
Okay.
Thank you for your time. Is there anything else you want to share with anybody? Anything?
If you can come out and learn some FST, it'll change your life. You know, get work done, find a practitioner who's local, have a treatment, and then get interested because this stuff is great and it can affect the world. It can change the world. So get out there and give it a try.
And if people want to see you, where do they get in contact?
They come to Penn State Hershey Medical Center, Hampton and Holy Spirit Hospitals in Harrisburg, Pennsylvania. And they can contact me by my email. It's smbonin1@yahoo.com.
Okay, and you give FST sessions to people who not in the ER?
I do. I work at Evolution Barbell and I do sessions by appointment. So you can give me an email and I'd be happy to help you out.
That's awesome. Thank you.
Thank you.
Bye-bye.
Bye.